Thank you, Mr. Chairman, and thank you for the organizing committee and responsible for inviting me to take place in this wonderful meeting. I'm enjoying it since yesterday. And it is under the title of IVF in the Future, but I want to convince you that the topic I am about to talk about is actually the present and not the future. So let's have a look at the mysterious lady, the LH. This is my disclosure. Now, predictive factors for pregnancy in ART are the positive ones, are the number of oocytes that we retrieve, the number of embryos that are available for transfer, but also very important, the quality of the embryos that we are transferring. And this is one of the latest meta-analyses to look at gonadotropins. More than 6,000 cycles have been collected in the meta-analysis. And as you can see, recombinant FSH is responsible for a higher number of oocytes to retrieve. But if you look at the pregnancy rate and implantation rate, adding recombinant LH as a conclusion of this study, meta-analysis shows that it will increase the outcome, and especially recombinant LH added to recombinant FSH was superior to all other combinations that have been described. And the same in the latest Cochrane Library database, where they stated in the conclusions that moderate quality evidence that the use of recombinant LH with recombinant FSH may lead to more ongoing pregnancies than just recombinant FSH alone. So where is the magic? Should we LH or should we not LH in our treatment? Just to remind you a little bit of physiology, T cells have through all the cycle presence of LH receptors, and they are important for producing the androgens. LH receptors on the granulosa cells will basically appear in the mid-cycle development of the follicle, but LH via androgens has an effect on the granulosa cells from the beginning of the cycle. And this is because it will increase the granulosa cell sensitivity to the FSH receptors. Klaus Andersen's group has shown that even in very small granulosa cells, they have found activity of LH receptors, but they dramatically increase toward the middle and the end of the cycle, while FSH receptors diminish. So the follicle is becoming more and more LH dependent. And Marc-André Serrat stated that the real competence of the oocytes will need not only a nuclear maturation, it's not only a metaphase 2 oocyte, but you also need a cytoplasmic and a molecular maturation to have a full competent oocyte. And this competence is achieved, as you can see, in the late follicular phase, which is LH dominant and not FSH dominant. A study done and presented at the ASRM in 2008 from Richard Scott group showed in 19 patients undergoing egg donor in long agonist cycle compared to 9 control groups. The control group received recombinant FSH through all the stimulation, 300 units, and the study group, they stopped the recombinant FSH when the lead follicle became 14 millimeters and just continued for another 2 or 3 days with 300 units of recombinant LH. And what they found was that the percentage of good developing day 3 embryos and day 5 blastocysts was significantly higher in the group that received recombinant LH at the second half of the stimulation. They did show a tendency in the implantation rate and pregnancy rate. It didn't reach significance probably because of this very small number that have been used. We repeated that in my center, and These are now antagonist cycles receiving recombinant FSH plus recombinant LH according to our criteria between 150 to 300 units. And on the last 2 days, when follicles reached 14 millimeters, the 2 lead follicles, we switched to only 225 units of LH for the last 2 days. And what you can see is that the number of the oocytes in the advanced maternal age was significantly higher in the study group that received recombinant LH. But the pregnancy rate per embryo transfer, and Norbert will excuse me for that, was significantly higher than in the control group in all age groups, and the same was for the implantation rate. So how much LH is needed in the treatment? Well, LH activity which is required is probably very low, because studies have been shown that even if less than 1% of the receptors are occupied, there will be enough LH activity during the stimulation protocol. Of course, a hypo patient will definitely need recombinant LH in the stimulation. And previously it was found that very profound downregulations with ultra-long agonist treatment might also need LH activity. But I will show you that there are even other situations, especially in the antagonist protocol, that there will be a situation of very low LH. And this is one of the studies coming from Australia, where they looked at the day after they started the antagonist and measured LH. And they found a subgroup that LH dropped below 1 unit, which was for them a situation like a hypo. And in this subgroup, they showed that there was lower implantation rate and lower pregnancy rate compared to the group that didn't drop. Then they did a small RCT and gave to this group that dropped 75 units of recombinant LH from the first day of the stimulation, and they found that they could correct the outcome of the treatment. There was no difference now between this group receiving recombinant LH of 75 units from the first day to the group that did not drop. When they reanalyzed the data retrospectively, they found out that this situation of drop of LH under 1 after the starting of the antagonist occurred in 50% of the antagonist cycles, which is quite a large number. Another paper coming from the Taiwan group, and they looked about association of low episodes of LH in an antagonist cycle and pregnancy loss. And they found that about 22% of the patient dropped less than 0.8 international units anytime during the stimulation, and 1/3 of them even before they started the GnRH antagonist. And the more episodes of low LH occurred, the higher the probability was to have a miscarriage if a pregnancy occurred. The other biggest group that is suffering from low LH will be the aging group, the patient with the aging ovary. So we know that androgen production is reducing during our age up to 50–70%. And this is due to less functional LH receptors on the Teca cells, also less Teca cells by themselves. But also the endogenous LH that's produced by the elderly woman is less potent and biologically less active. And you have the evidence down there. Also, there is an impair of the paracrine system. All the growth factors are impaired in the aged ovary. So what does it mean? When we have an abnormal LH situation in a long agonist or antagonist protocol compared to the normal situation, we try to overcome it by high doses of FSH. So what the high doses of FSH will do, it will enhance the paracrine system and will make the Teca cells more sensitive and the LH receptors to very low amount of LH. So the system will continue working normally. So this works very well in the young patient, but in the older patient, the paracrine system is defective. So we cannot compensate just by increasing the amount of FSH in this subgroup of patients. And what LH is done, so here's some evidence from the literature. LH will increase ovarian follicular angiogenesis by upregulating VEGF-A. It will improve follicular recruitment because it will make the granulosa cells more reacting to the FSH. It will increase follicular maturation by upregulating all these growth factors. And we also know that it will upregulate growth factors like FGF2, amphiregulin, and epiregulin, which are synergistically acting also with IGF-1, which are important to the development of the follicle. It is known that LH will reduce the apoptosis of cumulus and granulosa cells, and apoptosis of these cells might have an implication on the quality of the oocytes that will grow in the follicle. And it is also known that there is an enhancement of the expression of anti-apoptotic proteins by LH. So a study group published this paper last year, trying to look at what are the subgroups that really there is sufficient evidence in the literature to recommend to use recombinant LH. And as you can see, it was quite a high number of records that we were using, not so many RCTs in there. And we could identify basically two subgroups, but there really was sufficient evidence to suggest to use recombinant LH in the stimulation protocol. The first group was the so-called hyperresponder patients, and the second group was the advanced maternal age above the age of 35. All the other subgroups that you might see down here, there was not sufficient evidence to suggest to use recombinant LH. So what is a hyperresponder? A hyperresponder is a patient with adequate ovarian reserve but unexpectedly low number of mature follicles and oocytes, and it is shown by the so-called FORT, or follicle output rate, and it has something to do with the different sensitivity of the ovaries to the FSH stimulation. Nowadays we have a new marker called FOI, which is more or less the same. This looks now at the number of oocytes retrieved per number of antral follicles at the beginning of the situation, and we have normal FOI and low FOI. So you will see the situation of a hyperresponder that the follicles stop growing at around day 6 to 7 after starting the stimulation. They just stagnate. And there have been several suggestions how to rescue the situation, and increasing the dose of FSH or adding HMG or adding recombinant LH. Well, the results show, and here you can see some of the studies, that the best rescue was to increase to add recombinant LH. It was much better than increasing the FSH. Adding HMG did not change the situation, and adding 150 units of LH seemed to be better than just 75 units just to rescue the situation. For the next cycle, it meant to add 75 units from the first day of the stimulation. So what is causing this different sensitivity? Well, one of the reasons are the polymorphism of the FSH receptor, and especially the serine-serine homozygote is responsible for that, and that will occur in about 25% of your patients if you measure for polymorphism of FSH. The other group, which happens in about 15% of the population, is the beta variant of LH, which is a very short-acting LH, but very low bioactivity. And this happens in about 15% of the population that we are treating. And there are, of course, also LHCG receptor polymorphisms. Again, the serine-serine situation of LHCG291 and LHCG312 require more stimulation and adding recombinant LH. So here the meta-analysis, the forest plot, you can see that in hyperresponder, by adding recombinant LH, it significantly increased the fort, and it will increase also the implantation rate. And in the advanced maternal age, you will see again an improvement in the implantation rate, but there is not more oocytes. You will not increase the number of oocytes if you add recombinant LH. So what does it mean if you have the same number of oocytes but better implantation rate? It means that you improve the quality of your oocytes. Now, reports show, especially in the advanced maternal age, different results. So now you will wonder, why do we have different results? Well, the reason was, if you look at the studies, they started the LH on different days. Some of them started on day 1, and some of them started on day 6. So this study, the PERSIST study, published in 2015, looked into this issue and compared advanced maternal age, starting recombinant LH from the first day of stimulation, or starting recombinant LH, adding to recombinant FSH from day 6. And what they found was that by starting on the first day, you significantly have higher implantation rate and better outcome of the treatment. So the end of the story is that if you decide to use recombinant LH, you have to use it from the first day of the stimulation in order to see a result. Another topic that was tried to look at was poor ovarian response, because there have been previously some meta-analysis publications to suggest that by adding recombinant LH, it will increase the number of oocytes by 1. And that will have an implication of the relative clinical pregnancy rate. So this was the largest study, they called the SPART study, which looked at more than 900 patients, which are Bologna criteria poor responders. And one group received recombinant FSH and LH from the beginning, and the second group received just recombinant FSH monotherapy. And the first aim of the study was to see if we can increase the number of oocytes, but as expected, there was no increase in the number of the oocytes between the two groups. But in the post-hoc analysis, when they looked at the different subgroups of Bologna criteria, and you know that Bologna criteria is not a homogeneous group, it is just a number. But if you look, you can find 13 subgroups in the Bologna criteria. So if you look at the more moderate and the severe subgroups, they found, and in this group, they had a lower pregnancy loss with recombinant LH and a significantly higher live birth rate, which means, again, that they increase the quality of the oocytes if they don't increase the number of the oocytes. Another way to use recombinant LH is to use it before the stimulation, priming of the TICA cells. And this study has been published in 2014 from the Bologna group, where in extreme poor responders with very poor outcome, you can see the poor outcome here from the previous cycle, they started, before starting with FSH stimulation after downregulation in long agonist protocol, for 4 days, 150 units of recombinant LH, and only then they started the stimulation. And what they found was that they increased the outcome of the treatment, so a higher pregnancy rate, higher implantation rate, and higher delivery rate, and less miscarriages. And in my center, we repeated this study and had a look at our very, very bad poor ovarian response patient, and we basically achieved the same results by priming them for 4 to 5 days with 100 units of recombinant LH prior to starting the stimulation, and we could increase the pregnancy rate per started cycle. This is now per started cycle, the pregnancy rate and the implantation rate. When we use the Poseidon subgroups that you heard already this morning about it, group 1 and group 2 are definitely hyperresponder patients because they have unexpected less number of oocytes with a good ovarian reserve. They only differ by the age. So in these two subgroups, recombinant LH supplementation will be the choice to correct the situation. Group number 3 is the ASPART group, the poor responders, expected poor responders, which are young. In this patient, it has been not shown in the ASPART study that LH will be of any benefit. These patients are young and they have very good euploid oocytes, so the probability, even if a lower number of oocytes to achieve a pregnancy is quite good in this patient, and one can use double stimulation just to increase the number of the oocyte. Group 4 are the so-called ASPART moderate and severe ones. These are the ones who had a better live birth rate by using LH in poor response. So in this group of patients, LH supplementation will be also a benefit of the group. So you can use now the Poseidon subgrouping to make decisions on which group you would like to add recombinant LH. What are potential sources of LH? Well, you can use the recombinant one, and you can use urinary LH, where you are expected to find 75 units of LH. Only you will not find LH, but you will find HCG. And the reason you find HCG is because of the high purification nowadays. It was different maybe 40 years ago. And the LH molecule is lost. So the companies add HCG to have LH activity. So you would ask, does it make a difference? Well, it seems to make a difference, because although they have the same alpha chain, they have different beta chains, which make the HCG molecule more long-living. Half-life time is 3 to 4 times longer than the LH, and it has a stronger affinity to the LHCG receptor. So both of them attach to the same receptor, though the receptor can differentiate which molecule attached and will react according to the attached molecule in the different pathways that we have. And we have the cyclic AMP pathway, which is important for steroid production, and we have the phospho-ACT and phospho-ACT pathway, which are important for viability of the follicles and the oocyte. And studies coming from the Modena group showed that LH has a very good effect on the viability of the cells. HCG has no effect at all. Caspar-3, which is important for apoptosis, is increased by HCG, not by LH. And if you combine FSH and LH, or FSH with HCG, which you have in HMG, for example, then you will reduce the viability of the cells if HCG is together with FSH. So to summarize the finding of this group, HCG is more active, 5 times more active on the cyclic AMP than LH, but a lot of cyclic AMP is pro-apoptotic in the cell. LH is more active on phospho-ACT and phospho-ACT. So LH is an anti-apoptotic growth differentiation and survival factor, and HCG is a steroidogenic but pro-apoptotic factor in the follicle. If we look at potential other problems with the HCG, because of the long half-life time, it will accumulate in the cell, and because of that, there will be a downregulation of the LHCG receptor. And this is exactly what you don't want at the end of your stimulation situation. And it happens on the level of the ovary, but also happens on the endometrial level, and you see here the evidence from the literature. So it can also interfere with the implantation in the uterus because of that. And so LH and HCG are not the same, and they are not equivalent. In clinical outcome, we compared in this publication in 2011, almost 5,000 patients divided in 3 subgroups according to the stimulation that they have received. And you see here that by using recombinant FSH and recombinant LH, you significantly a higher implantation rate and a higher pregnancy rate. When we looked at the live birth per started cycle, it was significantly higher, not only in the older patients where we actually expected it, but also in the younger patients. And a nice side effect, a paper coming here from the South group, to show that if you use LH and FSH to LH 2-to-1 ratio, you will decrease the probability of having a premature progesterone elevation at the day of the triggering. So it is a nice side effect that you might also use in your daily clinical work. So what do we do in my center? We analyze the population that we are treating. Our center is now almost 40 years old, so we're getting mostly secondary, tertiary, or even fourth degree patients. And we figured out that about 95% of our patients will fall in either of the group of hyperresponders, old advanced maternal age, or very severe poor responders. So we decided not to bother, because they only come for one cycle in our center, not to bother discussing which one will receive LH and which one will not receive LH, because it will be only 5% of the patient. And this 5% will not be harmed by 75 units of LH. Also in my country, there is no difference in the pricing between FSH or FSH plus LH. It's the same price. So economically, there is also no problem. And we decide on the dose of the FSH component according to what I call the triple A and triple R, which means the age of the patient, AMH, AFC, and the three relevant receptors, FSH receptor and the two LH receptors. And according to that, we decide on the dosing of FSH and LH. And just to show you some result, this is just a part from a paper that we published this year. So I just wanted to emphasize on the number of oocytes that we achieve in every group of age. And if you can see, the metaphase 2 percentage is very high in all subgroup, and the same for the implantation rate. This is just the live birth rate per embryo transfer. It is per embryo transfer because some of the patients we don't transfer in the fresh one, because we use a lot of the ERA test for the implantation failure, so we cannot transfer in the same one. So I just use now the live birth rate for those who were transferred in the fresh one. So these are all fresh transfer, and you can see that it is quite high in all age groups. So to conclude, we can say that LH given during ovarian stimulation exerts stimulatory effects on FSH, dependent granulosa cells activity, steroidogenesis from the beginning of the cycle, and this is why it's important to start on the first day. And in these subgroups that I mentioned, hypogonadotropic hypogonadism, very severe poor responders, older than 35 years old, and patients who are hyperresponders, one should give LH from the first day of the stimulation. And you should remember that LH and HCG are different on molecular, functional, and clinical levels. Recombinant LH, they produce predominantly HCG is pro-steroidogenic and potentially pro-apoptotic, and LH is predominantly pro-growth differentiation, mutation, maturation, and survival factor. Thank you very much.
We have time for one question, and Dr. Silber is running to the microphone.
Robert, that was really powerful, very useful. And I wanted to ask you, if we can't get recombinant LH, is there any way we can use an agonist or even use a lower dose of HCG, a tiny dose, to try to get the same effect? Because I see what you're saying is absolutely exactly accurate.
Well, I always prefer to go to the origin and use the original stuff. You will not see the same results. You will not see the same results.
Okay, so using any way we want to manipulate HCG, we're not going to get such good results. So can we do that with an agonist? Somehow they're getting endogenous LH in the early part of the cycle.
No experience with that.
All right, thank you.
Okay, one last question, and then we're going to move on.
Thank you very much. Brilliant presentation. You said you subtype. You test the subtype of FSH and LH. Is that correct? So what do you do if you find a different subtype of LH? You just increase the dosage, or?
Well, we check for the LH receptors. So this means that you will need, so if you find an FSH receptor polymorphism, you definitely need to give LH, and you have to increase the dose of FSH by about 75 units. If you find LH homozygotes or heterozygotes, you will definitely need to add LH in these patients. And the one with 291, you will also need to increase the FSH dose.
Thank you.
Okay, thank you very much.
Thank you.